As a reminder, this podcast covers sensitive and sometimes difficult medical topics. Listener discretion is advised.
Hey, everybody, and welcome to episode 2 of No Referral Required. Welcome back.
Hey.
Hey. Hi. We are all here.
Laura, Mandy,
and Courtney, and we actually have a guest with us today.
Our first guest!
Our first guest! Hooray!
We need an applause round.
I know. Woo!
We'll work on that. Okay.
We can do the old-fashioned radio shows where you just, somebody's walking, knock on the door. Yeah,
sound
okay.
effects.
That's what it is. That's what I should have done in my other job.
A Foley artist?
Yes, that'd be so fun.
Right.
Okay, anyway.
We digress.
Yes, but our first official guest is with us.
Welcome, Josh.
Thanks for having me.
We're so excited. All
Very
right.
excited.
So, we decided that these first few episodes should be something that the majority of the population, when they visit the healthcare system, might have some interaction with. And so made sense that we have a general OB-GYN practitioner, since greater than 85% of American women will see one in their lifetime. I'm not sure what happened to those other 15%.
I know, gosh.
I know,
What are they doing?
15 seems high for never having seen one.
Yeah.
Yeah,
Honestly,
guys,
guys, go see your doctor.
Yes. Yes, please.
But that is a high number. So we decided we would start with that. And so Josh joins us. He is a Nashville OB-GYN in private practice, but didn't start out that way.
That's right.
Started in academics with myself and Laura. And so that's how we know him. Josh, why don't you start by telling us about yourself and how you got into the practice of OB-GYN?
Well, thanks for having me. This is super fun and exciting, and I'm honored to be here. But I grew up in South Carolina, in the upstate, and lived there pretty much my whole life. And ended up going to Wake Forest for undergrad. Spent 5 years sort of doing I'm single and I can do whatever I want stuff before I settled back down and decided to go to med school. And OB-GYN was my last rotation as a third year.
We hear that a lot.
Yeah.
From people who go into it.
And
Like they put it off for some reason.
I know, right? I don't recall if I actually put it off or it just happened to be that way. Right. But it was clear that I didn't really have too much of an excitement about doing OB is what everybody called it, right? No one knew about GYN stuff. They just called it OB because you just deliver babies.
Just birth babies.
Yeah.
That's right. That's all it is.
And but so I met an attending during my rotation there that sort of perked my interest, and he and I connected, and he sort of put me under his wing and said, "Let me show you what it's really like."
Oh, nice.
And he did. He showed me not just the day-to-day activity of what he did and what the job entailed, but what's it like at home. He was married with kids, and this is what it's like, and this is how it could be if you do this kind of job or that kind of job. And on top of that, the actual job was a lot more exciting and stimulating than I thought it would have been for some reason. I was going to be a pediatrician from day one. Yeah.
Oh. I could see that too.
Yeah, I can. Yeah.
There's probably a deeper story there. My dad was an OB-GYN.
Oh, okay.
And so I saw I saw what it was like for him. When I first noticed that's what he did, he would get all these phone calls at night.
Yeah.
And I
Dr.
didn't.
Huxtable.
Yeah, exactly.
Was he the old school too?
Right, and he didn't have to be at the hospital like you do now. There came a time, I don't recall how old I was, where I remember him talking and saying, "Well, I can't stay home anymore. They're requiring me to be at the hospital."
Oh, yeah. So in-house.
In-house.
Yeah.
And so we would go, whenever he was on call, we would go eat dinner there.
Oh.
We'd take dinner there, go get pizza, or we'd make dinner or something and go there and sit with him. And then we would all leave and he would stay. And then many a times I would come home from school and he'd be on the couch just out after a long night of call. And, so I was like, I don't think I really want to do that. And he's always at the hospital. But my friend, Dr. Coe was his name, in Broward General down in Fort Lauderdale, sort of tweaked that interest back in a way that I thought, you know what, I need to look into this a little bit more.
Yeah, that's really interesting that you had two different practitioners that had two different experiences speak into your life that gave you a different impression.
Very much. Yeah. So I sort of switched gears a little bit and did a couple of rotations as a fourth year, and that sort of interest persisted enough for me to say, that's what I'm doing.
Yeah.
And so ended up training at Vanderbilt and stayed on there after I trained.
And now you're in private practice.
Yep.
And that was a big change for you.
A big change.
I don't think you saw that coming.
It's very interesting. One of my colleagues who was involved in the development of the practice where I am now called me one day and said, I just wanted to let you know about a thing I'm doing. And I listened to it and was like, that sounds awesome.
Good for you.
And she, right. And she said, well, do you know any doctors that would be interested? And I said, no. And, she said,
Wishing.
right.
Good luck.
She said, well, if you hear of anybody, let me know. I said, no problem. And I don't remember how long it was between that conversation and when I got a phone call again, and it was more of the like, what about you?
Right.
I was like, well, I haven't really thought about it. To be honest, I haven't considered that. And she said, would you consider? I said, well, yeah, why not?
Yeah.
And so, one thing led to another.
Right.
And it was a timing thing. There were some other things going on at the job I had at the time. And it made sense. Looking back, my wife would probably disagree with that in some form or fashion, although she's very aggressive with the let's take some risks and do something that's like hard in life. That's kind of her MO. She's like, take a challenge. Why not?
Yeah.
And so, it was the right time. It was a timing thing, but it was the right time. Yep.
All right. I'm going to ask like one more of my questions, and then I'm going to let somebody else talk. So let's talk about the elephant in the room, and that's your Y chromosome.
Oh.
So as Laura and I practice, we often hear from women, I think because they're fine telling it to us, because we are women, that they would never think of going to a male OB-GYN because he, quote, can't understand what I'm going through, end quote. I don't put much stock in that. I'm not sure that there's a lot of other specialties that we require them to experience the degree of illness before they practice said specialty.
Yes.
I mean, I can understand where they're coming from.
Sure.
But let's talk about the trend of women predominance in, or women dominance. Predominance?
Predominance, yeah.
Thank you.
Yeah, I think so. It's like 80% now.
Yeah, in OB-GYN.
Yeah.
And the career.
Okay.
And how that's affected you, or has it affected you? Do your patients talk about it? What's your experience?
Man, that's a long conversation.
Longer than we have today.
Maybe longer than we have. I will say, in my training class, I was the only male. So there were 6 of us, and the other 5 were women. And of the 24 of us, there's 6 per class at my training institution. I think there were 3 men,
Right.
maybe 4.
Wow.
Yeah. So in OB-GYN training nowadays, it's persisted. Like there's maybe 1 every class, maybe 2.
Yeah,
it
my
is-
residency class was 0.
Mine was
Really?
one. Mine
for
was
yours.
1 out of 6.
Because once you lose even 1, it's hard to
Yeah.
recruit.
Right.
That's right.
Recruit back.
Yeah.
So I wouldn't say that affected me in any way. I think I approach women's healthcare in sort of this fashion. When someone says something like, you could never understand, right? Something like that, which not many people have said that to me. Maybe they think it, but they've not actually like voiced it. But I try to approach that human on that level, which is, you're right. I don't.
Yeah. I mean, how much can you
Can you?
I
limit
do not
even
understand.
anybody's
Yeah.
anybody
Yeah.
as
That's
a
right.
doctor, right? Unless you've literally, but
That's right.
Even then, your
Yes,
expense will be
everything is so different
in a
for
different
each
context.
person. Sure.
Right.
Yeah, I think if you show any human, not just in women's healthcare, but any human, any form of compassion towards something, a relationship sort of develops in a way that it would not otherwise. And so that I'd say that is the way I practice. I come at patients that I take care of trying to grasp an understanding of their life in their shoes and trying as best I can, which I can't understand everything, to give them the understanding that I care a lot about you and what's going on in your life, your marriage, if you're married, your kids. One of the things I ask for from patients who ask for what can I do for you, and it's very simple. Send me a picture of your kids. I want to know how your kids are doing. Right,
The ones that
I
delivered.
delivered.
Yeah.
And I probably have 30, maybe more. Every once in a while, I'll just get a photo. Just say, hey,
fun.
he or she's 1 or 2 or 3, and that's what you asked for, so I'm doing it.
Yeah.
So
That's such a good idea. I need to write that down. Write
Yeah.
that down to send my OB freaking pictures, because
Keep you
one of them
going,
graduated
you know?
from 8th grade, so
It
that's
does.
like
Yeah,
you know a milestone or whatever.
it's
so
a huge.
That's very sweet.
I'd say that issue doesn't. I wouldn't say it's something I think about a whole lot because it doesn't bother me.
Because you're able to make a connection no matter
Yeah,
what,
I don't.
human to human.
I haven't had. I mean, I don't think. I don't think I've had much of a problem establishing trust in the women I take care of, just because I'm a male.
Your human factor has exceeded your gender.
Well, I hope so.
a knowledgeable
I hope
doctor,
so.
right?
Yes.
I know people with a Y chromosome who happen to be OB-GYNs who are like that, and it's a struggle.
Yeah.
It is. It's a struggle.
I've seen one.
Yeah.
My current one is not that, but I've seen one that I was like, nope.
I mean, that's a pervasive thing in the world.
Yeah.
Women are basically taught, this is what you do. This is what I do. You stay in your lane, I stay in my lane. And when it comes to women's healthcare, it's don't question the doctor.
Yeah.
Don't even ask a question. Don't even think that you could think about talking about things that you want to talk about. Just keep your mouth shut. Whatever he or she says, that's what goes. And there's obviously space for discussion, but there's a pervasive behavior of I'm the doctor. You do what I tell you. You don't have any voice in this. And I think that creates space for distrust and potentially outcomes that are not great.
What do you think about, I know so many women who their OB-GYN is their primary care also. They don't maybe go see a PCP anywhere else. Is that what you see? Is that a good practice as a patient? Or do I
am a lot of women's only solo practitioner.
Yeah, right.
Yeah. And I would say I feel pretty comfortable in most spaces doing that.
Okay.
Nowadays in training, there is a lot more training for OB-GYN residents in the spaces of typical primary care.
Right.
Right. Now, if you have really bad diabetes or
Yes.
really bad high blood pressure, or
Would you refer them to a specialist?
Sure. Yeah,
Okay.
I mean, that requires a lot more follow-up
Yes.
and engagement with not just you, but your staff.
Right.
Just to make sure patients are not falling through the cracks with certain conditions.
Okay.
But, if you want to call me for a sore throat or get a strep test or anything that's sort of like I would call my PCP for, I can do those things.
Okay.
Feel very comfortable.
And that doesn't cross any kind of boundaries that you have.
Not for me.
Okay.
I think there are some people out there that it would call your PCP.
Yeah.
I don't have time for that.
Right.
I do pap smears and I deliver babies.
Right.
That's what I do.
Right.
Yeah.
Yes.
Very narrow.
So,
Yeah.
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 So
So your day-to-day, a typical week for you, because you do surgery as well, or no?
I do.
Okay. So what is a week in the life of an OB-GYN look like?
For me, it is a full 24-hour labor and delivery shift.
Mm-hmm.
So I go to work at, say, 7 a.m. And I go home the next day at 7 a.m.
Monday through Friday?
No.
Okay.
1 day a week.
Okay, 1 day a week. Okay.
The next day I have off because I'm probably wiped out. I'll see patients 1 to 2 days per week
Okay.
during that same week.
In clinic.
Yep.
Okay.
And then I'll probably have either a half day, sometimes a full day, but more usually it's a half day of surgery.
So
And
it's pre-scheduled C-sections and
C-sections or gynecologic
Yeah. Yeah.
surgery, hysterectomy, things like that.
okay.
That's my typical week. And then I also have to cover weekends. And we typically do somewhere between 36 and 48 hours straight
Okay.
over a weekend, say a Friday, Saturday kind of thing.
Yeah.
Once a month, once every 6 weeks,
Okay.
something like that. So
Okay.
it's not terrible. When we first started this practice, my partner and I were on every other night, 24 hours.
Because it was just the two of
that's
you.
hard.
And yeah, it was
Gosh.
rough.
Yeah.
It was rough.
Yeah.
It was rough. But now we have more physician partners so we can spread it out a little bit easier. So it's a lot better. It's a lot better.
Okay. When it comes to childbirth, and this was just me being, because I'm the non-medically trained one, but I think I was surprised having a first baby, and you probably get this, I would assume, reaction from lots of first-time pregnant women, is you're not, if you were my provider, you would maybe not be the one to deliver like my child. And y'all are all like, well, duh. But that's a big wake up call because I go to see you every week, every month or 2 months, and then every week at the end and all that kind of stuff. And then you're like, but we've had this whole thing. And like,
whole
we have a birth
relationship.
plan,
Yeah.
all that silly thing that doctors are like, that's funny. There's that. How do you explain that to somebody? Do you find it that people have that understanding? They think like that, and you're like bringing them to the world of reality? Or do people walk in already knowing that? And I'm just
Some people do.
okay.
But the person who might not, I try and grasp an understanding that they have about what their expectation is, so that they think that I don't think that I think you're a lunatic. Like,
Okay.
how could you dare think that right? And
Right.
that would create this sort of
Then I'll call
like,
for you
oh my gosh, I wasn't going with calm down,
Yes.
how
Right.
could you think I would be there 24/7?
Right.
So I absolutely understand why a relationship that has developed over 9 to 10 months of 2 or 3 humans, if your partner's with you, right, would expect that partnership
through.
to finish out.
finale,
Yeah. Right. The big moment. I need you to be there.
Right?
Yeah.
I think a lot of physicians in an ideal world would love
Absolutely.
to be there.
Sure.
That is the highlight
Okay,
of somebody
yeah.
you'd follow.
That's
Yeah.
right.
You
That's
cared
right.
for this woman
Yeah.
and their baby for so
Yeah.
long. And,
But I mean, how many hours in what you just described in your week? That's a 60, 80-hour work week, usually?
If that description is exactly what I do,
Yeah.
but it's not every week like that. So it averages about 50 for me, which is not terrible. I can work like that. At my previous job, I had sort of worked myself into sort of like a 6-day work week, which is a problem.
yeah.
It's challenging.
Yes.
And a good portion of that was actually work from home,
Oh, right.
catching up on stuff that I
The
didn't have
catch-up
time
charting.
for. But no, I
Everyone's
I absolutely understand why women would be confused by that. I do.
Yeah.
I absolutely understand.
Yeah.
And I say, I get to be me too.
Yeah.
I have an awesome wife, and I have 4 kids.
Yeah.
I get to do that too.
Right.
Right. And I've had one patient in my career since 2007 who has said, I can't do that then.
Huh.
I'm gonna have to go somewhere else.
Oh, interesting.
Wow.
And she did. And I was
Okay.
like,
Great.
by all means.
Yeah.
Yeah.
I sent her to someone that I trusted who
Yes.
did that.
Yeah.
She said, I'm doing that.
Okay.
And there's plenty of people in many metropolitan areas, including Nashville, that's their MO.
That's how they operate.
Right.
That's
Someone's
their
on
commitment.
call, right?
Yeah.
Of their practice. Someone's on call. But if you come in and you were my patient and I'm not on call,
You have to come in.
My partner's going to call me and say, she's here.
Yeah.
What do you want to do?
Yeah.
You come in, you get paid. You don't come in, she or he gets paid.
Yeah.
So that's a lot of people come in. They're at home eating dinner. They drop everything and come in.
Well, I mean, I know I said Dr. Huxtable, but that was my understanding was the Cosby Show was like he was just always, he saw people in his office at their home and then he would go into the hospital and carry his little briefcase thing, and be on call. Oh yeah, I got to go see Miss So-and-so. She's having a baby and, whatever. So,
I think the model in the 50s, 60s, and 70s
was very
much that. But the number of patients you followed was enormously
it wasn't
less.
85% of women?
No, I mean, maybe it was twice a month.
Okay.
So you could do it.
Yeah.
But in the modern model, you have these huge patient panels and you're seeing them. And there's probably somebody delivering every night in your practice.
For sure.
It's just not the same. Yeah. But I think a lot of people, I think even the physicians would like that, if you could follow fewer and deliver 2 or 3 of your own patients a month. I think
absolutely.
But I just don't see how that structure can work.
Yeah, it's
in
not
the
feasible.
payment
And it's
system
not
anymore.
financially
Yeah.
That's right.
So Courtney mentioned something that I wonder if it's a bad word, and that's birth plan.
Oh.
Is that a bad word in your practice?
Not a bad word.
No?
You welcome it.
Absolutely.
Yeah.
To what extent? What does that look like? What's a healthy
conversation,
one to
or-
have? That's like realistic, because some people are like, I want the lights down low. I want this music playing. I want this exact song to play as the baby's, being born. I don't want any medical intervention that's not, what necessary. Like, what's the line that like you can? I don't want to say guarantee because that's never medicine.
Right.
There is no guarantees, but that you can try your best, and it makes sense. It's not a big ask.
Right.
Is there a line?
I mean, it's gray.
Okay.
Yeah. I mean, of course there's one. And I don't know what it is. And
until you're in the moment.
Neither do the parents.
Right.
They don't either.
Yes.
Neither of us do.
Okay.
And until we all come to that agreement, it can be challenging, right? I mean, a birth plan can be as simple as like, I just want to have a healthy birth.
Sure. Yes.
That's my birth plan. And, it can go all the way to I want the dad or the partner to deliver the baby. I want them to do immediate skin to skin right there. I want the cord to stay unclamped until the placenta comes out. That's a thing. It can be very, very minutia when it comes to details of a birth plan. And I think the issue on really either side, whether it's the provider side or the patient side, is some kind of a control mechanism.
Sure. Oh,
right?
yeah. It's the scariest thing
you've
probably done at that point in your life.
Right. And again, I don't know that a patient's trying to control anything other than wanting to have a birth that she wants to have.
Yeah.
Right. What's wrong with that? There's nothing wrong with that. My control is, no, I need the birth to be, I need to not have a bad outcome.
Yeah, right. I don't need to lose either one of you here.
So if your birth plan navigates a space where there's a potential for something bad to happen, I'm not going to let it happen.
Sure.
I'm going to put my hand down on that one.
Right. Yep. Is that different per provider? Like you have a different line than maybe somebody that you work with, like in your same practice?
For sure. Yeah, I'm currently I'm way more comfortable with navigating birth plans with anybody that wants to have one.
Okay.
Because I know at the end of the day, I have no idea what's going to happen.
Right.
Right. I have no idea.
Yes, it's not a contract. It's just a plan.
And all I can do is choose to be engaged and present in potentially something that is difficult during a birth.
Yeah.
And not necessarily shame someone for having a crappy birth plan.
Sure.
Right. I mean, so what's wrong with having any birth plan that anybody wants, right? Even if there are things on there that potentially are unsafe.
Yeah.
Right? And those things occur, right?
You tell them? You say, like, this part I'm not sure about, like, ahead of time.
That's right.
Yeah.
You have to be honest. You can't just, pull the wool over, right? You have to be honest
Your
about
blood pressure is really high. We're going to give you some magnesium. That's going to happen.
right. And so then
right?
what do you do when said person says, I hear you, I'm not doing that?
Woo.
Do you then not take care of them? Do you make them feel bad?
What do you do?
I tell them, here's why I think this is the healthiest thing for you to do.
Sure.
I understand why you wouldn't want to do it. I try, again, even there, I try to say, what would it be like for me to step foot into that person's...
Yeah, in this moment,
Right.
with the emotions
You
and
feel
hormones.
this way, and I want to know why.
Yeah.
I want to engage you. And she still might say, I'm not doing it.
Yeah.
Well, I can't force it on her, so I don't. Right? But that doesn't mean I quit taking care of her.
Yeah.
You know, like I still am there. If she has a seizure, which I've seen,
Yeah.
right?
I'm sure.
I have to do something.
Yes.
Right? And,
Say, if
you know, I
don't
think...
do this, this could happen. This
That's
is
right.
what I will medically have to do to keep you alive.
Correct. Yeah. So it does make the space a bit more nerve-wracking.
Yeah.
Because you're always in this like, what's going to happen kind of stage. You know, but that happens even in folks that are like, I just want a healthy birth.
Right.
And
I was going to ask,
they
do you
come
feel
in
like, do you
and they're,
feel that in
my
every birth? Like,
there's it's the job that I do, if in at least in the obstetrics world, it can happen in gynecologic surgery, but it's more common in obstetrics where you kind of always feel like there's like something around the corner
oh,
because there
Feeling of
is.
dread.
yeah.
There always
Like, this
is.
is why we're not in obstetrics anymore.
And that would be why I left.
That's right. Well, the reality of the situation is there always is something around the corner.
Sure.
You just don't know when it's going to happen
Yeah.
or who it's going to happen to. And we have all these risk factors. And if you have these 4 risk factors, you have a higher risk of having this, that, and the other.
Right.
But you can have the healthiest mom show up who has
something-
no
yeah.
problems
Yeah.
and she gets sick.
Right.
I think
Right.
that is one of the scariest things.
So you kind of always have to be prepped for anything. And it makes it psycho-emotionally grueling.
Draining. Yes.
Yeah, it's grueling.
What's the most scared you've ever been in a situation?
In a labor and delivery
Yeah,
unit?
yeah, labor and delivery. Well, because you do so much more than that. Maybe I don't want to narrow it down that much. Like,
No, it's a labor and delivery real deal hemorrhage, blood loss, where you've done everything you know how to do and nothing's working.
yeah,
And at my previous institution, I could call 10 armies and they would all show up.
yeah, right.
Now I work in a smaller institution, more of a community hospital.
Sure,
And it's me
it's you.
and an ER doc at night. That's it.
Yeah.
There may be a medicine person on call taking ER admissions, but there are typically like 3 doctors at night.
Yeah.
And so if you call your partner to say, come help, it's like 30 minutes.
Right.
So you got 30 minutes to figure something out.
Yikes.
Blood loss that you can't fix
Okay, that's the scariest thing.
is incredibly scary.
Right. It's already a very bloody procedure
It can be. Yeah.
because we have more blood.
Yep.
Right. That's what I was told.
Yeah.
Yes.
Yep, you're right.
Okay.
So
That's why Nathan
I
was
would
like,
say
there was
that-
your blood
yeah, there was-
everywhere. And my doctor was like, it's because she had more to begin with. It's not like we were just
yeah,
Body
spraying
plans
it
for it.
everywhere.
For sure.
Yes. Right.
for sure.
Right.
Yeah, those are probably the scariest moments
Okay.
where you feel out of control,
Yeah.
like, because you've done everything that you were trained to do, and
and you're-
she's still
Which is a
bleeding.
long list of steps,
It is.
too. You know?
Yep,
Okay.
it is.
Yeah.
It's super. Luckily, those kinds of things, when you get that far, they're actually pretty rare.
Okay.
The things that you do in line that you're supposed to do, something works.
Okay.
You know, but I could tell you a couple stories of like none of that worked.
Ugh.
None of that worked.
Yeah.
And it's frightening.
I just think.
And just saying that out loud, by the way, whoever's listening,
Uh-oh.
like an OB-GYN said they were scared. Is that allowed? Are you allowed to be human?
Yes.
Right.
I am.
Well, I think
I am.
so
Yeah.
many.
This is what we wanted to show people.
Right. So many Americans, at least. I mean, maybe other countries, whatever. But you think that that medicine is a final thing. Like it's a set and cut and dry. This is what happens. You literally go into a hospital. You come out with a baby. Baby and mom all come out. You know, that's kind of because that's what we want to think about. We don't want to think about the miracle that it is that two human beings come out of the hospital. You know what I mean? So I think it's good to hear that. It's good to hear that you're fully aware of this. None of those things are a surprise. You're anticipating, you know, that's what I want to hear. Like, okay, if I'm walking into a scary situation, I at least want the doctor to be like, all the way around.
It could be.
Yeah, I've seen
know what
things.
we're gonna do.
Yes, I'm ready. I have 10 backup plans and all that kind of stuff. So,
Yeah.
Anyway,
So 60 to 85%, I found this statistic online, of OB-GYNs are sued at some point in their career. I mean, you've mentioned a lot of things that could lead up to that. I'm not going to ask you if you've ever been sued. But if you know anything about that process, that would cause a lot of people to leave their career. So working through that, I think, is a huge success for people when they're able to separate that and still treat women knowing that there is always something around the corner. Can you talk about that?
The stress. Yeah.
The stress of that.
Yeah. You know, it's probably, it is, other than, well, it could be on the same plate as getting a 3 a.m. phone call about your 20-year-old kid that something happened.
your own child, yeah.
Right. Which, too numerous to count, parents have gotten that call. I've gotten the call. Right. It's like the thing you fear the most, the 3 a.m. phone call. Right. It's in this profession. And again, it could be obstetrics or gynecologic. I've had some difficult gynecologic surgery outcomes that I still feel to this day like I did something wrong. And no one can tell me any different. Right. And some of that is health. Some of it's actually sickness
Okay.
on my part.
Yeah,
That's
sure.
why I see a therapist.
Sure.
So,
Oh, very good.
Yeah.
We can touch on that.
But you're a human. You're a human. I think everybody
Right.
has that experience, no matter what your
Yes.
profession. I did that wrong. You know, and people say, no, it was all blah, blah, blah. But you still feel it.
very
It's
much.
hard not to take it on.
So,
Yeah.
you know, and I could be maybe 1 out of 100. I don't think so. I think some people just hide emotion. I don't. I'm a very emotional human. And so people know when I'm not feeling great. They can just tell.
You don't have a poker face.
Right.
It's okay.
And so when it comes to that, I mean, it is probably the thing that I think there's probably an idea out there that patients or the general public thinks that specifically in our field, do they even care?
Sure.
Yeah.
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 Do they know what they put us through?
Yes.
They've done.
Yeah.
And
Especially going back to the male-female thing.
right.
Yeah.
Right,
That's
yeah,
another,
adds
like-
another layer.
Yeah.
Yeah.
Well,
Men don't know.
I mean, what I will make this very short and sweet. Like, I care. I carry things at night. I don't sleep at night. I weep, tears shed over babies, moms, dead moms.
Right.
I've done two obstetric cases of mothers that died, and it will never not be off of me.
Sure.
Ever.
Yeah.
And that's not anybody's fault. It just happened to me.
Yeah.
And I don't think I did anything wrong, but it still happened. And I mean, I carry that stuff every day of my life. And yeah, the whole like suit thing is a challenge in this country because anything
Yes.
any outcome can be sued, right?
Right. Yeah.
And it's a scary thing because it becomes more of a personal vendetta sometimes. I mean, sometimes, you actually did something bad. Sometimes. But most of the time it's just, if a kid has a bad outcome, it costs money to take care of the kid, a lot of money.
Yeah.
And so I don't blame people for doing it because some people don't have that kind of money to take care of the kids. So some of that's the reality of the situation. To take care of a kid that has needs, it costs money, right? And that's how they get it. I get it. It still feels really bad that your name is pinned on it.
Like insult to injury.
Yeah.
Like you're already sad about the outcome, and then
Terribly sad.
something else happens.
Yep.
Yeah.
I mean, I have a colleague that we probably talk every single day. And it's not necessarily about I need you to hear me and then fix the way I'm thinking incorrectly about an emotion, because emotion is emotion. And we talk just to say, I'm saying this out loud to you so you can kind of hold this with me. And so I'm not hiding the way I feel. Because if I hide the way I think, I start thinking really badly about me.
Yeah.
Spiral.
Yeah. But if I say it out loud to someone who understands,
You bring it to the light.
yeah,
Yes.
it's easier to live with.
Sure.
But it's a thing, Mandy, that it's a daily thing for most OB-GYNs to carry some form of this is hard and it's painful and there's a lot of joy, but the hard things and the painful things are hard and painful.
Yeah.
And they don't just rub off.
Yeah.
You carry them for the rest of your career. I do.
Does it affect choices that you make in the future with patients?
Great question. It's one of my sort of most difficult births was what's called an assisted birth.
Okay.
Where you use either a vacuum or a forceps to help a baby get out. And so that was a very challenging birth. I still use those instruments.
Okay.
Despite that. Now, the first 5 or 10 I did after that, I was heart rate 200, I don't know, do a C-section on everybody, right?
Just forget it.
Just C-section everyone.
Well, some people do that.
Yeah.
And,
that leads to a whole other host of problems.
Sure.
I think the answer to your question is yes and no. Yeah. I think the sort of the heart rate 200, there's part of my body that's trying to teach me something pay attention.
Right.
This is serious.
Yes.
Pay attention.
Yeah.
Right. So it's supposed to do that. But it is hard to train your brain and body to say, do the right thing.
Right.
Yes, this outcome over here didn't go like you thought.
Yeah.
But that doesn't mean you did it wrong.
Yeah.
It just means that it didn't go well.
Yeah.
Is that yours to blame?
Sure.
I mean, birth is beautiful and traumatic in the very same field. It just they share the same fence post.
Yep.
It's beautiful and very traumatic. I mean, just think about the idea of a human being fitting through.
Yes. The physics or the
It just doesn't make any sense.
space
right?
planning of this doesn't. Yeah.
So the idea that it is safe and it's like what you see on TV is just not reality.
Yeah. My OB had a doctor or had a patient who he was not even like his partner was caring for her when she was having a baby, but she took off the belt, the heart rate monitor, to go to the bathroom while she was in labor. And between that time and coming back, the baby died.
Good Lord.
And nobody knew.
Wow.
Because it, takes a minute to get the things back in the place and all that. So he would not let me get up. I could not.
Because of that.
I mean, I could get up, but I had to stay attached to everything. I was not allowed to do it because I was like, oh, my birth plan was that I wanted to walk and bounce on the ball and blah, 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 all those things, which I am not downplaying any of that. I wanted to do it. And he was like, I don't let people do that because of that.
Yeah.
He said, it was very
shared the
early
story with you.
in his, and I was
Okay.
like, okay, when you tell it like that,
Yeah.
I get it.
it makes more sense
Yeah.
to me.
Totally.
I don't want to hurt you. So, yeah.
Let's move from let's move to the logistics of the practice a little bit. So there's a lot of ways to practice medicine, and more patients will be like, well, I don't even see the doctor anymore. Now I see the
PA
or the NP or the midwife in practice. You know, historically known as mid-level providers, but I don't think that's a very PC term anymore.
Oh, that does sound
So we
offensive
don't-
to me when
Yeah.
you say that. I'm like, oh.
We try not to use that term. But just in case someone's heard that term, that's what I'm referring to. How does that work in your practice? And what do you feel like has been like the boon of that? Like, how's that helped things? And do you feel like it's detracted at all?
Yeah, I mean, I think our practice is a collaborative model. That means we have physicians, midwives, and nurse practitioners who work together to take care of humans who happen to be women. And I happen to think my sort of way of thinking about healthcare is that is probably a safer and better model than a true one-on-one. Because I think people are able to connect with different humans throughout that care model.
Yeah, more eyes.
Right.
Mm-hmm.
And potentially you have people who say, well, I saw this or I caught this, not that I missed it,
Right.
but
Yeah.
you just saw it.
just had a
One
different
day it showed up and
conversation.
one day it didn't.
That's right.
Yeah.
And I think the sort of the older model of doctors have to do everything. We can't. I can't do it all.
It's too much.
I just can't. So I happen to like that collaborative kind of model. That's what I practiced at my previous institution. That's what we did. And there's actually data, at least on labor and delivery units, where if midwives are sort of the lead professional on a labor and delivery unit, the outcomes are better. Just generally speaking.
Okay.
And that probably has a range of reasons.
Sure.
I'm not sure there's one reason for that, but and it's not like we, just to give the doctors a break, because we still have to get calls from the ER, and we still are involved in labor and delivery, obviously. But I think the idea of having humans connect with more humans to see where do you establish a better relationship, it works better when it's not just one person, I think. And I can see why there are folks that say, no, that's my person. I am only going to him or her. I will not see anyone else. And I actually have those people in this practice who are like, I will not see anyone else. I will only see him. And, I think the hard part about that is, hopefully it never happens, but it sometimes does, where someone like that realizes, like, I'm just as human as that other person over there who you said you didn't like. I just am.
Yeah.
I just am. And so I may have a bad day. Now my wife says, you aren't allowed to have bad days. At least when you're delivering babies, right? Yeah. That's their moment.
Yeah.
You can't have a bad day. And, there's some space in the middle there where both are true, right? I can be human and have a bad day and show up for a human.
Do you think that gives you more space in your personal life, emotionally, mental space? You talked about your dad coming home and you were like, oh, I don't know that I want that, but then you chose it. Do you think, considering his home life and your home life, I know there's lots of factors that go into that, but as it relates to your profession, do you think having a team of people has made it more tenable for you to practice medicine?
For sure.
Okay. So
For
definitely a more positive outcome for everybody involved, patients and doctors.
I think. Yes. I think it is. It's a way better model than that sort of single care system.
Okay.
And single care system stories are out there that are really good.
Yeah.
I just my sort of way of flow of life needs a more collaborative care model than the one-on-one.
All right, before we get into our speed rounds.
He didn't laugh. He smiled. He
It was a
smirked.
punt, a medical punt.
I'm going to ask one more question before we do speed rounds. So one of the things about OB-GYN is this mass exodus from rural practices where we can't, the country can't sustain them. So if we picked you up and plopped you in a rural setting, what's the first thing that you would do?
If I'm alone, am I alone?
Yeah, you're alone.
Hire a midwife.
Okay.
Huh. Great. Yeah.
And a nurse practitioner. That's what I would do.
Do you feel like it's the lack of support? I'm sure it's multifactorial. But as someone who's in private practice, what do you think is the main issue there?
In rural healthcare?
Yeah.
For
OB-GYN.
Yeah, I mean the financial the numbers on paper in the women's health world don't work.
Yeah.
I take care of.
It's not sustainable.
It's just not.
To have that kind of practice.
Okay, I take care of women for 9 to 10 months. Okay, and I can see them for 6 or 7 or 8 visits, or 10, 11, 12 visits during the pregnancy, and I get paid the same. It does. So each visit is not a billable visit. That's actually changing in like 6 months, where each visit becomes a billable visit.
Yeah.
Really?
But no matter how acute or sick they are.
That's right.
Or healthy and easy.
Correct. And that's for a general OB-GYN. If I actually send them for a consultation to a higher level care, they can bill them a consultation fee. Right. But I don't.
Right.
Right.
Well, nor could you.
Nor could I. That's right. And so when you take that and then you move into more rural areas where there is a higher population of underinsured patients, then that number makes even less sense because the reimbursement from that insurance company is less. And so the way to do it or to survive is you have to see 3 or 4 times the number of patients compared to a middle downtown Nashville practice seeing only commercial insurance.
Right.
And it's not sustainable.
No.
You can't live as a human like that and do it safely.
Can't run a practice.
And then you just break even, by the way.
Yeah. And
So
be tired.
and you're exhausted, and you have no
yeah.
life, and your spouse is ticked, and your kids don't know you, and not to mention you don't get to be your own human. Like
Right.
you don't get to do the things you want to do.
Right.
And that's sort of the MO and the more rural communities, I would say in Tennessee, but probably in most states. That's the concern. You cannot financially sustain a practice model that requires people to just see more and more and more. And then instead of seeing patients over a 30-minute window, you back it up to 20, then to 15.
Yeah.
Because that's the only way you can make it work financially is to see more people, do more things, right? And
Everyone suffers.
I think, for sure. Yeah.
Yeah.
Sort of a reflection of what we value.
Yes.
And it's not always women's health in rural areas.
Right. Yeah.
Yeah. I mean, I don't know exactly what I paid my gastroenterologist to do my colonoscopy, but it took him about 15 minutes.
Yes. Right. And I didn't I said hello and then I was asleep. Like I didn't even know.
Seriously?
Yeah.
I know, right?
It's
And
frustrating.
You saw someone for months.
Or I do a tubal ligation on somebody that is not a great surgical candidate, so I take some risk.
Yep.
And I get paid a couple $100.
Right.
Right. And you can't. You have to do hundreds of the surgeries to make it work.
Right.
Gosh.
And I think on top of that, we sort of negotiated the space of lawsuits and whatnot. But as far as malpractice and what it costs, I think we're number 2, maybe 1 with neurosurgery.
Yeah.
I'm not sure who wins out there.
We're always up there. There's a little teeter at the top.
Yeah. So we carry that as well. And yet the reimbursement for what we do, there's a lot into finances when it comes to women's health, especially labor and delivery. Lots of hospitals want to keep the NICU sort of, let's have better outcomes. Let's take care of moms better so that they have better outcomes, which means they go to the NICU less.
But they want to fill the NICU.
But you got to fill the NICU because that's how That's how we make money.
There's a
Yeah.
lot of competing priorities.
So you can imagine from a human perspective, if I'm in the middle of that space trying to do the right thing,
You're penalized.
I have lots of things that are
A
pulling,
lot of levers going.
saying, this is my priority. Yeah, but this is my priority, and this is mine, and this is mine. And eventually, if you're just a good human, you do the right thing.
You just do what you
Right.
Just do the right thing,
Right.
Yes.
right? And if they go to the NICU, great. If they don't,
Great.
great.
Yeah.
Okay? But again, you have to live in that space day in and day out. And it can be exhausting.
You have to get those spreadsheets. And you're like,
I don't care.
okay, speed rounds.
Speed
This
rounds.
is the fun part. Okay, so we got a
Quick
list of
answers.
quick, not too much thought. So, are you superstitious?
No,
Okay, I feel like so
wow.
many of us in medicine are. I'm
Good for
terribly
you.
superstitious.
not at all.
Okay. Okay. What other specialty do you have to ask for help the most from?
General surgery,
Okay. Okay. Is that more on L&D or more with GYN?
GYN.
GYN. Okay.
And that's mainly because
That's who you have.
that's who I have.
That's who's there.
I don't have a gynecologist.
Right.
Yeah.
I don't have a minimally invasive gynecology surgeon.
Yeah,
I don't have
yeah.
that.
Yeah.
That's who I have.
What's a word or phrase you end up saying multiple times a day?
All things.
The words, all things.
All things.
Okay. Okay. Give us an
Give us a
example.
context.
You said you said this was like rapid.
Oh, yeah,
rapid.
speed.
Okay.
I
we
can.
want
I
to
can.
know more. We want to know more.
Okay,
Give us
elaborate
the
on that
context.
one.
You do want me to?
Yes.
Just
So how
give
do
us
you
an
say-
example.
yeah.
How would you respond to all things?
I'd say over the last 10 years, I have navigated spaces where I am confused about why said thing happened. And I think I've sort of lived in this space of like, I need to reduce the number of bad things happening and increase the number of good things happening because that's the way it's supposed to be.
Ideally.
And if the number of bad things happening they tend to be, this is the way my mind thinks, reflective of something about me, as opposed to, no, it's just a bad thing that happened.
Yeah.
And where my counselor and some friends of mine have sort of helped me navigate is actually they share the same fence post, and they have to.
The good things and the bad things.
So they all belong.
So all things belong.
I don't like that.
That's not the
I don't-
way we
That's
want
a
it.
Mr. Rogers
I
moment.
do
You can
not-
have two emotions at the same time. You can
I
have
don't
both.
understand. It's too mysterious for me to navigate why a baby that died or got hurt or a mom that died has to belong. I cannot explain that. I won't. I can't even think. But I don't know how else to do it other than to have belief that it can be mysterious, that they all belong. Everything belongs. All things. That's what that means.
That was a
I like
deep
that.
theological.
That was deep. I know. I'm glad we
yes,
got
moment.
the expansion on that. Who in your inner work circle could you not live without?
A name?
Yeah,
Like
or
a role,
Title or
a
position.
role, or
Wait, say that again. Sorry.
who in your inner work circle? Who can you not get through your day without?
My
And-
partners.
Okay.
My physician
Yeah,
partners.
your colleagues.
Yeah.
Who do what you do. What other medical specialties gross you out? I think we all have one.
Gross.
So mine's anesthesia because I can't do secretions.
ortho.
Blood?
No, the
Bones?
bone.
This,
Sorry. Like if someone comes in with a dislocated toe, I'm on the floor.
Probably GI.
okay,
I
that's
don't
a
like
good
poop.
one. That's a good one. Okay. Fair. Fair.
Probably poop, and they're in poop all day long.
From start to finish.
Yeah, I know, right?
Would you encourage your children to pursue a career in medicine?
Of course.
Okay. All right. And do you have a joke about your area of medicine?
That's clean.
This is that
No.
we can say on it.
No, I don't.
So many OB-GYN
I'm sure there are. I just don't have any. I would love to know one.
None in your back pocket. You know?
No, none in my back pocket.
I got
Okay.
a question that I thought, did you deliver your own children?
I delivered my first kid.
Okay. And then decided no. Or did your wife
The other
decide
ones you
no?
mean?
Yeah.
My first kid was 34 weeks, and she broke her water.
Oh, like you didn't mean to deliver her.
No,
was
we
an
got to the
accident.
hospital,
Okay.
and I'm like, this is not real. And the nurses were like, it's very real.
Oh,
She broke her water
It's
and she's 5
happening.
centimeters.
Uh-huh.
And I don't know. I think we got there at like 6 a.m. and by noon he was born.
Wow, for the first.
Right. So the attending rolls up in there, and I think the nurse had told him that I was a first or second year med student. I think I was a second year.
Oh.
Oh, wow. You haven't even done residency yet?
No, he's like, he handed me the gloves, and I was like, I didn't have a clue what I was doing. I was a second year med student. I hadn't touched
sure you were
anybody.
terrified.
Right. He said, put the gloves on. So I put the
At
gloves
this
on.
point, I'm just going to say, Josh, there's no way you were ever going to be anything other than an OB-GYN.
Right.
I mean, your dad, OB-GYN,
Correct.
your mentor,
Yeah.
OB-GYN. Your
So I delivered
delivery.
Marshall. Eli, my second, was breech.
Oh, okay.
And she didn't want to do a version. So we did a C-section.
I like that sound for the
Yep.
vision.
It works. Yeah.
And
Yeah,
then
baby.
Sounds like the poop
my
conversation.
third, Gabe, was I was a second year resident in training, and I just knew too much.
Oh, yeah.
So I was like,
scary.
I'm just the dad.
Yeah.
Oh,
I told them to turn the monitors off.
okay.
I don't want to look at the tracings.
That
Yeah.
would.
So they would just have them at the nurse's
Yeah,
desk.
so they had them outside, but in the room, turn the monitors off.
Man, can you
nothing.
do that? Oh, that would have been nice because that's
And then
stressed me
when the
out.
birth happened, it was one of my favorite attendings who did it. I just said, I am dad.
Yeah, I'm on this side.
Isn't
I
that
am
funny?
dad.
The more you knew at each stage.
Less you want to be involved.
Yes.
So I delivered Marshall.
Okay. All right. That's fun.
All right. Final question. If you could do any job in the world outside of medicine and still
you had
support
to.
yourself.
You had to.
Yeah, you couldn't do OB-GYN anymore. What would it be?
I think my wife Brandy and I's sort of dream job, whether or not it would like financially support us, would be to create a space where it's either like, I mean, it's kind of still, fizzling a little bit, whether it be like a coffee shop kind of place or a B&B, something like that,
Yeah.
where people came back to say like, I want to go see them,
Yeah.
and we remembered them. And we say, oh, yeah, how's your house, this, that, and the other. And we sat and had
Regulars.
breakfast with them, had coffee, had a drink at night or something. Something like that, whether it be here or, on a beach somewhere.
Yeah.
I don't know, but something that created tons of space for humanity to be together. Something like that. Yeah. We still talk about it often, and we're nowhere near it.
Maybe that'll be your retirement gig.
There you go.
You could host people at,
I have a long way to go. My little girl is only 11, so I have some
Okay.
work to do, unfortunately.
But that's the kind of OB-GYN I want to have. Somebody who wants to be hospitable. Like,
Yeah.
I want a doctor that, likes people.
Yeah.
And it sounds like very much, I'm just meeting you, that you like people.
Well, I think the thing I love about my job is helping to create spaces where women can feel like I can trust this guy and his team of people that work with him. Like, I don't know what it is, but I'm going to keep coming back to you.
Yeah.
You create a space that's comfortable.
Sure.
And I can say anything. And I can say, I might disagree with you. It's okay. I can disagree with you. You can disagree with me, and we can still be friends.
Yeah.
Kind of thing.
Yeah.
Yeah. So yeah, I think that's true.
Okay. Well, thank you for being here.
Thanks for having me.
It's been so great.
Great.
So, yep. Y'all make sure you're following us on Instagram, and we will be back soon.
Bye-bye.
Bye.
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 This podcast is intended for informational and educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views and opinions expressed by the host and guest are their own and do not constitute medical guidance for any individual case. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or health concerns. Never disregard professional medical advice or delay seeking it because of something you have heard on this podcast. By listening to this podcast, you acknowledge that the hosts, guests, and producers are not responsible for any decisions or actions you take based on the information discussed.